Thank you for your kind introduction. We'll today talk about the implementation and barriers of shared decision-making in critical care medicine. The overview would be, I will first like to discuss the importance of SDM in the ICUs. Now I'll move on to the current status and the barriers that we face in Korea, and also to the future directions, how to overcome these barriers for a better SDM environment in our ICUs. So why is SDM important and also very challenging in the ICU? It's because that in the ICU, usually it's a very life-threatening conditions, and the stakes are very high. It's usually a very life-death situations. And the decisions needs to be rapidly made, so you don't have time to talk in detail about each situations. And usually the critical care, critically ill patients do not have their, they lack the capacity to make their own decisions. So usually the family or the surrogate decision makers are available, and it's another problem talking with them about treating the patients. And usually the ICU is very complex interventions, and for each interventions, you need to do a decision-making process. And lastly, the outcomes are very uncertain. Some patients get better, they go back to their general wards, they get discharged, but some also die in the ICU. So the outcomes are very uncertain at the time of the admission to the ICU, which makes it very difficult to do the SDM. I think the very important part of SDM is first the patient prognosis, which is very uncertain, and the patient's preference, and also the risk and benefits of treatments that are given. So the patients usually have a choice of getting an invasive treatment or a very conservative management. And usually the conservatives are just non-invasive ventilation, just medical management, and do not resuscitate. But if you go into the ICU, you will have a choice of getting an invasive management, which will include medical ventilation, sometimes ECMO, renal replacement therapy, tracheostomy, and other various surgical interventions and CPR. So the risk and benefit assurances and the management are very important in the management of the critically ill patients. What are the barriers to the successful SDM in the ICUs? To understand the current landscape, I think it's very important to first review the history of the end-of-life care in Korea. The pivotal event was the Borame Hospital incident in 1997. There was a middle-aged man with brain hemorrhage who was in a vegetative state after surgery. And his wife requested a withdrawal of life-sustaining treatment and wanted discharged. But afterwards, the patient's doctors were convicted of negligence and murder in 2004. And this event created a deep-rooted fear of legal consequences among physicians, which led to a more cautious and a passive approach in making critical decisions. Another turning point came in 2008 in the Grandma Kim incident. This was an elderly woman who was in vegetative state for more than a year. And the family requested withdrawal of life-sustaining treatment, but because of the previous incident, the hospital was reluctant to perform it. And in the later years, the South Korea Supreme Court ruled in favor of the withdrawal of the LST, which was the first legal recognition in Korea of the right to die with dignity. And this incident led to the introduction of, we call it the well-dying law, but it's actually the Act on Hospice and Palliative Care and Decision on Life-Sustaining Treatment for Patients at the End of Their Life. And this actually formalized the decision-making process for life-sustaining treatment at the end of life. And this is in 2018, so it's a very recent act that was enforced. So what happened in Korea after this law was enforced? Well, like I said, this law was enforced in 2018, and I had the privilege of being part of a team that studied the impact that the law had on the healthcare workers. And we have seen, and this was published in 2022, and we have seen that the medical staff acknowledged that the quality of death was improved after this law was implemented in the ICU patients. But also an interesting thing was that before the law and after the law, if the patient thought that the deceased patient needed withdrawal, did you do the withdrawal? Before the law, it was 40%, but after the law, it became 60%. So I guess you could say more physicians were more positive, more confident of withdrawal after the law was enforced. But why did you not withdraw the patient even when you thought the patient needed withdrawal? The main reason was, the highest reason was disagreement among family members, and it was still the highest reason after the law was enforced. So in the critically ill especially in critically ill patients, the main decision is not made by the patient, but is still made by their surrogate decision makers. And if they have a disagreement, it's one of the reasons that life-sustaining treatment is not discontinued. So we have seen after this law that the policies do have the power to change the culture. In the broad sense, national policies can change national culture, but even in a specific changes in the institution policies can still change the institutional culture, and it will benefit the clinicians, and then in turn will benefit the patient and families. The next important part of SDM is patient preference. So what is the patient's preference? The well-dying law in Korea also puts the patient's intentions first. However, the problem is there is a cultural reluctance to discuss death in Korea. And although I've seen the culture is changing slowly, and many more people are talking about advanced directives, but still the end-of-life discussions are usually avoided. And that is the reason we probably don't know the patient's preference before they're admitted to the ICU. So, and there also remains a lack of full respect for patients' autonomy. The shared decision-making often becomes family-centered in Korea. And although it's important to include the family into these discussions, it becomes a little bit problematic when they become the dominant role. So, and especially in situations when they disagree. And also, family protectionism is also still a problem in Korea, where family members request the physician to withhold the truth because they believe that the truth, which is almost always the bad news, will distress the patients and will overwhelm the patients and make the results worse. So there's still a lack of autonomy, lack of respect for the autonomy in our culture, which is becoming problematic. This is a study done by our team that tried to see the factors that influence the decision to be admitted to the ICU in elderly patients. And the elderly patients in this study was defined as patients over 80 years old. And usually we thought these patients may not be a good candidate to be admitted to the ICU. And so some don't get admitted, some do. We wanted to see what influenced their decision to do so. And the interesting part was that among social economic status and the cognitive impairment, also the number of participants in the SDM influenced the decision to be admitted to the ICU. In other words, if there was a 1% increase in the decision-making process, it was more likely that the patient will be admitted to the ICU. We saw this as because there is more likely chance to be a disagreement. And if there is a disagreement, usually you go for the invasive, more aggressive treatment. So this was one of the factors that influenced the choices. And also another interesting part was, so we said this in the DNR decisions, but this is more likely who was the dominant role in the SDM. And we saw that the most dominant role was the offspring. It wasn't the patient, it wasn't the spouse, it was usually their offspring. Of course, they're all over 80 years old, so they were very frail, they were very old, but still their most dominant role was by their offspring, which was probably the reason we thought that will probably be associated with why they were more likely to be admitted to the ICU. Another problem of patients in the ICU is they have a limited capacity to make their own decisions. They could be intubated, they could be sedated. There are multiple reasons we're not sure that they have the full capacity to make good cognitive choices. But the problem is that they don't have an advance directive. So we don't actually know what their preferences were before they were sedated. So we tend to rely on their surrogate decision makers, which is problematic because it could be a very huge emotional burden on them. You make the choice and they have to make the choices that usually means life or death. And another problem we face is that are they actually adequate surrogates? Because legally, only immediate family is recognized as a legally bound surrogate makers. But sometimes as our culture is changing, more people are not immediate family, but other common law partners or other close companions. They might know the patient preference better, but they're not legally allowed to make decisions for the patients, which is also, I think, another problem in performing a well-organized SDM in the ICU. So in here, by the law, well-dying law, you can see that if you know the patient's preference, you only need two immediate family members to agree to withdraw life-sustaining treatment if it's not in the best benefit for the patient. But if you don't know the patient preference, all unanimous agreement among all immediate family members needs to be mandated, which is not a very easy thing to do. Another problem of critically ill patients is that they have a very uncertain prognosis. So when you admit a patient to the ICU, if you're sure that the patient is gonna deteriorate and expire, then you shouldn't admit them to the ICU. If you're sure they're gonna get better, of course you should admit them to the ICU. But usually they're in a very gray zone. You're not sure. Especially in an intensivist view, you're seeing the patient for the first time and you cannot make the very clear diagnosis of their prognosis. So usually if they're in the very orange or gray zone view, so you're not sure of their functional recovery. In 2011, it first became, there was a terminology that was introduced called time-limited trial. And it was an agreement between clinicians and patient family to use a certain medical therapies over a defined period of time to see if the patient improves or deteriorates, and change and pivot the goal of care at that time period. So time-limiting trial is for patients with uncertain prognosis and an unclear preference, or they haven't made their decisions yet. And then you decide to initiate all necessary treatment for a certain period of time. And then during that period of time, you undergo many sessions of SDM, and then through those sessions, you get a specific narrow goal, appropriate goal. And then you focus on patients and families' perception of improvement. There's a very huge gap usually between the patient and the family's perception of how the patient is going to improve, and between the medical professional's opinion. But then through these SDM, you close the gap. And then usually they have a better insight of expected quality of life, not just life and death, quality of life after being discharged from the ICU. And then with those closed gaps, we make a decision to whether continue intensive care treatment or discontinue treatment. We have also realized that SDM is not just for family members, patients, and medical personnel, but it's actually needed among healthcare providers ourselves. Because through the well-dying law, as you can see, the patients in the end of life, are they adequate candidates for the implement of the well-dying law needs to be confirmed by two doctors. And usually, I have experienced there's a difficulty in getting two doctors to agree. Usually one doctor is the doctor from the ICU, and another is a doctor who was previously seeing the patient at the outpatient clinic or in the general ward. In the medical culture here in Korea, it's still hierarchical, and it's a very top-down approach. Sometimes it's very difficult for junior doctors to actually say, no, I don't think that's the right case. And also in the previous morning session that we've talked about is more older people, more difficult to participate in SDM. But older physicians have a more tendency to have a fear of legal liability because they have seen the previous incidents that I've showed you in the previous slides. So there is a very different opinions among healthcare providers, which is also a hurdle, I think, in Korean SDM. This is an interesting multi-center study in Korea that asked what are the barriers to SDM? And although the questionnaire was not limited to the ICU, it was in general, but that most of them agreed that in the clinical field, SDM is not adequate, not satisfactory. And the most common reason was, I don't have enough time pressure. And the second most common reason was the request of the caregivers. The caregivers are very unrealistic. Their prognosis and expectations are very unrealistic. These were the top two reasons for the barriers of the SDMs by this survey. I believe this issue is probably common worldwide, but SDM is a time-intensive process. I've heard from the previous lecture it takes about 20 minutes or more or less, and it can be a burden for when situations with staff shortages and if they have already a high workload. I believe this can be a burden. Also, another problem is that we are not compensated. We've never been compensated for having discussions with patients and family members. We've only been compensated for medical procedures that we do. This is also an important factor in, I think, time and resource constraints are also an important factor in conducting successful SDM. Another current factor is that South Korean healthcare system is in crisis at this moment. And the national health insurance system covers about the 97% of the population. It is a fee-for-service basis, and the reimbursement rates are strictly controlled by the government, but we get extremely low reimbursement rates, especially for critical procedures and critical care like ICUs, thoracic surgery, brain surgery. And if we think about the ICU, we probably get only 60% reimbursed for the resources that we use, and we cover it up from other parts of the medical system. And also that we have a very high rate of criminal charges. It's much higher than Japan and UK. And also because the Korean government decided that they need to significantly increase the medical student quota next year, a majority of the residents and interns have resigned, and the majority of the medical students have taken absence of leave, which also impacted our system into having a shortage of staff. Another problem that many have said was that there's a lack of training and education. This was an interesting study, mainly by nephrologists and physicians and residents from 317 university hospitals. And they've said only 33.7% has said that the SDM was appropriate. And they have, and for the reason for inadequacy was the insufficient time, which is always a point that we come back to, and also the unrealistic needs of the family, but also lack of education materials and tools. So how can we make this impossible possible? First, the healthcare policy changes are very needed. We need legal protection for healthcare providers, and we need adequate reimbursement in general, and also for the SDM consultations and SDM-related activities. And this will dramatically, I believe, have the power to change the culture regarding SDM in Korea. Another is education and training. And I have been most fortunate to work in an institution with a strong support from the clinical ethical team. They are named as clinical ethical team and a palliative care team, but they have also been very influential in conducting SDM in our hospitals. And this was a project creating a series of case-based videos that address the challenges that we face in our hospital. And we have like a bad case SDM, good case SDM, and this is our real nurses and real residents working dressed up like actors. And we have through this video we've had very good reviews, and many from nurses and also doctors, and they've said, "Oh, I'm really glad that I'm not the only one who's very confused about how to approach this problem." And we've had very good reviews that it had helped them make decisions, to communicate and make good decisions. These are the educational programs developed by the clinical ethical team at our institution. And this is in Korean, so I'll point some out to you. Some of them are ethical questions. Is this decision ethical? But some of them are about SDM. So like, what can you do about SDM in the emergency department, in the ER? What SDM can you do? And also in the COVID-19 era, what changes in the SDM? And how can you discuss end-of-life care with the patient first? Because sometimes it's more difficult to talk with the patient about their end-of-life issues. So we do all these, we call them the clinical ethical ground rounds. And we do it in many different methods. We sometimes just invite many panels. Some are lawyers, some are social care workers, nurses, doctors, to talk about a case and what they think about the case. We have many people asking questions and actively making all these discussions. Surprisingly, at first, one or two meetings, many didn't come out forward to ask questions, to speak their own expressions. But afterwards, I think many actually did ask many questions and try to get actively involved in the discussions. Sometimes we have a video of a real life scenario and do even votings about what would you do in this situation? Do you think is the best approach? So the clinical ethical team also works as an SDM support team in our institution. If they receive consultations, they counsel the patient and the families. And then we get a different perspective of the patients and the families' wishes. Sometimes they never said that to us. So it's a very different, it's a good idea to get a new set of eyes on the problems. And then if the problem is really complex and if there are ethical issues, they will refer it to the ethical committee if they're very unresolved or highly complex issues. And the interesting part was so where do they get these consultations for help in the SDM? And from the last 4 years, you can see that it was mostly from the ICU. So ICU is a place where things are very complex, and it is more difficult for a healthcare team to have engaged in an SDM with the patient or the patient's families. So there needs to be also a cultural shift toward patient-centered care. I think we need to more promote patients' autonomy, and I think things are getting better, but we do need to go on more to that level. And to encourage advanced care planning, as I said, many do not have advanced care planning. And when you come to the ICU without advanced care planning, we do not know the patient's preference. And there needs to be a legal recognition of the surrogate decision makers. Like I said, it doesn't have to be immediate family. Someone else can have a more better idea of the patient's perspective, and they need to have their legal rights to work or speak in the patient's behalf. Time-limited trial is another factor that I think improves SDM in the ICUs, because prognostic uncertainty is one of the reasons why SDMs are frequently avoided by the healthcare professionals and also the patients and their families. And to manage this uncertainty, we do a time-limited trial. Like sometimes we do for 2 weeks, sometimes we say 3 weeks. When the patient is admitted to the ICU, we will say, oh, there's 2 weeks or 3 weeks duration. We will look to see if patient gets better or worse. And if the patient gets better, we'll continue the ICU care. But if the patient doesn't get better, withdrawal would be adequate. And we already have this discussion before the patient comes to the ICU. And when the patient comes to the ICU, and then it actually reduces the decision-making burden on both the medical personnel and the patient's family, because they don't need to decide at that point, oh, do I need to not engage in invasive treatment, or do I need to engage? It's engage, and let's talk about it. And the flexibility to pivot goals of care based on real-time outcomes. And actually, there are time-limited trial can probably help avoid over-treatment and also under-treatment. So in conclusion, SDM in Korea is still in its very early stages, and we do need to overcome many barriers. First will be we need legal protection, we need adequate reimbursement, and also education program and support for both the medical personnel, and although I have not mentioned it, for both the patients and their families, and a cultural shift toward respecting patients' autonomy, and a time-limited trial helps in the ICU. SDM is not a choice, but actually I believe it's a necessary evolution in the ICU. And through these very active discussions like today, I hope that we take at least baby steps toward that goal. Thank you.